with that, we're going to start our first article that we selected for the Pilon fracture series. It is on the Pilon map, fracture lines and comminution zones in the OTA AO type 43C3 Pilon fractures, written by Dr. Peter Cole. So with that, we'll play the video. Back to the first question, how did you come up with this idea of performing this paper? This concept of the Pilon map is very novel. I was wondering if you could kind of tell us how you came up with the idea.
Well, I love this story. It's really one of the favorite stories of my career as it relates to both my clinical practice as well as my discovery. I love research, and I love trying to prove that what we're doing is right. I like trying to figure out answers to questions and discover things we don't understand and make sense of things that don't make sense to me. And that's the story behind this situation. It was in the early 2000s, maybe around 2002 or 3. I went to do a tour and visit a particular vendor headquarters, and so they were kind of intrigued by the fact that I loved periarticular fractures, particularly of the foot and ankle, and so I recall the time when several engineers and product development people and I were sitting around a table. And they said, gee, we'd love your thoughts about, the reaction to a few prototypes that we have developed. And for the tibia Pilon fracture, they knew I liked Pilon fracture surgery. So they put them out on the table and I looked at them. And these were developed by, of course, big league experts in the field, and of course I'm just starting out in practice. The first thing that occurred to me was, wow, every single one of them is completely different than the other. They were not at all like each other. They didn't go on the same part of the bone. They weren't the same sizes. They didn't have the same screw vectors, and so a light bulb went off in my head. Like, how is it possible that 3 so-called Pilon experts come up with a completely different concept to fix the Pilon fracture? And I saw a lot of conflict between these implants. And in fact, the implants didn't really seem to address the things that I was experiencing as a Pilon fracture surgeon. Probably the biggest issue was that, at that time, Pilon fractures were essentially always fixed with a medial-sided plate. So I thought, okay, this is a bad way about of going about designing an implant. Simply asking an expert what they want. And that's the way it happens all too frequently. And so what I thought was, what if we actually created a data set that would inform the development of an implant? And so it's probably surprising to people that that is actually what the vision of the project was. It started with my assessment of current implant designs for tibia Pilon fractures and thinking, no, this just doesn't seem right. I don't think the screw vectors are right, the location of the plate, and so on. So I thought, well, I think the way to try and to understand this is to identify the most common morphology of tibia Pilon fractures. And so I simply, took the CT cuts just above the plafond in 38 fractures and mapped them. And not so much to my surprise did I see things occur over and over, but I just didn't expect the consistency with which I saw it. Now, keep in mind in Jackson, Mississippi, in that period of time, we were dealing with 43C3 high energy Pylons in relatively young patients. I do think that there is a probably I'm not sure that all of this applies perfectly to fragility fracture variants or the Pilon fracture in the more elderly patient. This was a pretty typical high energy young 80% male population which made up these Pilon fractures. So what was interesting, of course, is the finding that you would see this, what I call the primary fracture lines. Those were the fracture lines that occurred in essentially every case. And then you'd see a lot of secondary fracture lines, which would establish the comminution in a tibial plafond. So that was so exciting for me to discover, and then go back to the same manufacturer and say, you see, this informs us what kind of implant we need. You know, where you want your raft of screws, how distal you need the plate, you know, where the plate is on the location of the bone in the vast majority of cases. I love the story, but there is something about the map which is visual. Like, all you need to do is see the map and you get it. And so it's a powerful a message to the operating surgeon. You know, it tells you where you want to be, what to expect, what you would want your implants to look like, what novel approaches you could develop. You know, it informs the surgeon tremendously, rather than going into what you know is a smashed fracture and you know, not necessarily being able to predict the things that actually occur over and over. I mean, in a rudimentary sense, it was sort of a first generation artificial intelligence, I suppose.
Another feature I really admired about this article, and I'm very grateful you got this published, you know, because we've seen this very unique novel concept of the Pilon map being replicated even in tibial plateaus. You mentioned scapulas. I even just saw it the other day on distal radiuses. So, you know, I definitely think this article is way ahead of its time. But I was going to ask you, was it always, you know, the concept of just the Y configuration by itself is enough, but was it always the objective to also look at the zone of comminution and impaction, or did you just happen to come across that? Can you tell us a little bit?
Yeah, yeah, absolutely. I think that the two go hand in hand. You know, I map the primary and secondary fracture lines, and so what becomes very apparent is that the comminution zones stand out. And so that was part of the mapping process from the very beginning, Arun. And I think a very key takeaway for the project, it tells you, you know, how injured the apex of the plafond becomes, because that central corridor from the fibular incisura to the medial angle is where the worst comminution occurs, right in the dome. I mean, that might seem intuitive, but you know, you really see it when you see a map. And then anterior lateral. You know, why were we fixing all Pilon fractures with medial plates if all the comminution is anterior lateral, and your primary fracture line is oriented in the coronal plane? You would want to lag that, right? So that's what was so powerful to me, and those two concepts did come along.
Great. Just to sort of wrap this up and conclude with our final question, you know, regarding the topic of Pilons, I was wondering what you thought were some of the knowledge gaps that we're currently facing on treating these devastating injuries. You know, where are some of the areas that we could really make future advances and future research in this topic of Pilon fractures?
Yeah, you know, I think it's interesting. Knowledge gaps. I think knowledge gaps and knowledge deficits are two different things. Knowledge gaps. The things that come to mind are, um, um, you know, what is the right stiffness of the implants with the surgical approaches that we use today. Um, how stiff do we want our construct, and do we want to think of you know, the working length and the stress and strain and modulus elasticity of your implants relative to the you know, to the long bone itself? I think that is one. I get the sense that many of our implants, for the type of biologically respectful surgery that we do today, are very over engineered. Uh, and I think another thing that comes to mind is the handling of the soft tissues. You know, it's always occurred to me that um, in some of the approaches we use for the Pilon, uh, anteriorly, you incise the retinaculum, and very infrequently can you repair it properly. Uh, so what is the role of the retinaculum? Why do we have one in the first place? And I think most of us probably feel that it's not a huge problem. We don't see bowstringing of the anterior tendons. But is that at the cost of emotion loss or scarring or symptoms that could be avoided um, if we were better at addressing an incompetent retinaculum? Same with the epitenon. You know, frequently you get into into the epitenon of the, you know, the extensor digitorum or the anterior tib or whatever, and I think, I mean, that is the blood supply to the tendon, and I think that's important as well. I'd like to know more about the pathophysiology there. You know, certainly, anything we can do to maintain or restore the resilience of articular cartilage is paramount. I think that, you know, most people tend to feel that the damage is done at the time of injury, and it's a little bit of a nihilistic thought, because I think if you over promote that idea, what tends to happen is that you are not as focused on a good articular reduction. I think the subset of patients that do better is larger if you have a stable anatomic reduction. So we shouldn't give up on the cartilage, but anything we could do from a biological standpoint to manage cartilage loss after Pilon fractures would be Nobel Prize winning work. And of course, a number of studies, clinical trials are being done as it relates to that in the setting of osteoarthritis. Has not really crossed over to the setting of trauma. I think artificial intelligence is actually something that will help to inform us more. So, for example, if you could really apply the different kinds of fracture patterns, the bone quality, the comorbidities to each patient and link it to a prognosis, I think it would help our decision making. I mean, there is certainly a subset of patients that would benefit from primary arthrodesis, for example. Um, and it would help with prognostication. And I think that the information, the data is out there to be able to do that. And there have been certainly some good studies. Um, for example, you know, out of shock trauma from Kevin O'Halloran and the group there, that is able to create a prognostication index based on certain risk factors. But I'm actually talking about something that gets down to back to the Pilon map, to the fracture pattern, to the amount of comminution and impaction. And if you could just plug all that all those variables into an equation, I think you'd have a pretty good idea of how a patient can do if you accomplish your surgical goals. Those are some things that come to mind. I think our evidence-based medicine, it leans too heavily toward so-called prospective randomized trials, and it doesn't necessarily help us individualize our treatments of one surgeon to one patient, because the results of randomized controlled trials, they apply to populations of patients and populations of surgeons. The results don't apply to any one surgeon and their patient. So we have to be really careful with that as well.
All right, great. We're going to go ahead and proceed to the next article. Keep in mind, just keep typing in your questions after this next article
Back
video.
to the first question, how did you come?
After the next article video, we'll kind of turn it over to the live authors, Dr. Cole and Dr. Mehta, for some questions. So keep typing in your questions.